right, we're back on air. This is DJ Bandit, but for this show, Raiye Matthews. We've got some other people in the booth.
Nice to speak to everyone. My name is Sid. I introduced myself last time as well. Miriam and I are back on, hoping to have a really good discussion today.
Yeah, I'm Miriam. So, I'm glad to be back this week.
PIHE at UT Talks, the second installment. If y'all were listening last week, we kind of just did an intro, expressed what we want this show to look like. And hopefully this week we can kind of get into the meat of it.
Yeah, I'm really excited because last week we had mentioned that we're going to want to get into some case studies of global health in countries. And today we're going to do exactly that. And we're going to get into something really interesting today. And it's the country of Rwanda. One of the countries that Partners in Health does its work in. Rwanda is an amazing country with amazing progress, listed as one of the top countries in Africa that is expected to have really good outcomes in the near future, one of the fastest growing. It's honestly quite tremendous as to what they've done. But anything that you guys want to say before we get into it?
Not particularly. I'm excited to talk, excited to hash some things out, share some stats, and kind of raise awareness to what's going on in Rwanda and what PIH is hoping to do about it.
All right, let's get into it. So just about 11 years ago, Partners in Health collaborated with the Rwandan Ministry of Health and opened the Butaro Hospital in the Burera district of Rwanda. Before 2011, the Burera district of about 340,000 people had one doctor. What do y'all think about that? One doctor for 340,000 people.
It's kind of unfathomable.
I know that, as a public health student, you use the World Bank website all the time. And you can look up how many physicians per 100,000 patients are in any given country. And you look at most countries and they have at least 100 or more. So sometimes when you're entering in countries that are maybe developing countries, you'll see as little as 0. And it's very sad to see. So something very important to discuss.
And just to provide a basis of comparison to everyone listening out there, we in Austin have a hospital bed capacity of one hospital bed per 375 people. You take that, you scale that up to 350,000. Imagine every time you get the flu, you get sick, you have a little accident on the playground, break an arm, and you have to travel miles and miles and miles, wait days and days just to be seen. Your health outcomes, there is no chance that you'll be able to experience the same level of health outcomes that we are able to. And even we have trouble at the height of the COVID pandemic. Hospital beds were overrun. We were not able to support the system. And you look at a situation like Rwanda's Butaro district just a couple of years ago, one bed for, or one doctor for 340,000 people. That's simply unfathomable to us.
And I mean, one thing about health is that if something's wrong, if you break an arm, or if you're ill, you require immediate assistance. That's not something that can sit and wait. But if there's only one doctor for 350,000 people, I mean, especially during the pandemic, I can only imagine what that looked like.
Yeah, and I think something interesting is that here in America, you still are required to be seen. So if you are experiencing something that needs emergency services, you are not allowed to be turned away from any doctor. You might get billed $1 billion later, right? But at least you can go in, and if you have your broken arm, that arm is getting put in a cast or a sling. So I think another thing is, like Sid mentioned, you're walking miles and miles to just be seen by a doctor. But really, if you look at different countries, so if you're looking at Haiti, they're not walkable paths, right? So you have to understand that it's not just you can simply walk. In Austin, I can walk to a doctor. This is a walkable city, right? And I can be seen by a doctor or somebody. There is a chance of even not being seen and then being turned away because you cannot afford it.
All right, let's get into how this happened. Why in 2011, a year not too long ago, in the grand scheme of things, how that situation ended up where there was one doctor for 340,000 people. And the progress that we've made since then, the progress we expect to make, and everything in between. So let's start with the condensed history of Rwanda from the colonial era. Rwanda was originally this kingdom with a social structure of two central classes, the Tutsi and the Hutu. These Tutsi and the Hutu, they were two groups that served two different roles in society. One was tended towards the land and cattle, and one tended towards the farm and crops. These two classes, it was mostly they looked very similar, they acted very similar, they spoke the same language. It was simply what they did in society that kind of differentiated themselves. As we all know, there was a large era of colonialism. Germany swoops into this country for whatever reasons they need in terms of resource extraction. They control this country and build up a lot of the systems around this resource extraction. A little while later, after Germany comes out of control after the World War, after the German Empire is forced to kind of give up control, almost in this weird way where the Allied powers have touted themselves as the saviors of the world, have beaten Germany, have beaten this evil German Empire. And one of those countries was given control of Rwanda because it is so necessary, apparently, to help these poor people survive, is Belgium. Belgium comes in and they come in with this touting this ideology of freedom, democracy. The Rwandan people are going to prosper. Instead, what they do, they segregate these classes of Tutsi and Hutu in order to control these populations. They segregate these classes and mark them because we see a lot of this idea of race and segregation of classes coming from Western culture kind of imposed on these communities where it didn't exist before. And that kind of created a lot of resentment among these social classes. These two classes kind of began to see a lot of violence between them because the Belgian rulers would favor one class over the other. They would give power to one and money to one and have a very heavy lack of care for the other. Getting into that, beyond that, when Belgium kind of retreated from this situation, that lingering tension that we're seeing there completely established the socio-economic relations between these two groups for the next 50 years. And culminated in this event that we tragically call the Rwandan genocide between the Tutsi and the Hutu. So yeah, I mean, let's talk about these patterns of repression that we continually see whenever we talk about countries like this.
I mean, we all know that European countries are notorious for their colonization efforts, like across countries in Africa, Sub-Saharan Africa, Southeast Asia, countries that they deem uncivilized, barbaric, whatever it is. They need someone to set them on the right path. I mean, we see this everywhere, and we see the long-term effects. I mean, I'm sure all of us can think of an example of like a long-term effect of colonialism on someone from a country of that has suffered from colonization.
And one other point that I want to include is growing up in the American education system, I always learned about this idea that sometimes this justification that European countries had in that these people are poor, less abled, they're not able to support themselves, and so we as a country who are more prosperous need to go into these countries to provide these countries with, or the populations with, workable environments. And we learned those things growing up, and a lot of our teachers would tell us to break down these foundational understandings, but we need to continue reading these history textbooks and continue evaluating how that ideology is present, even in things that they didn't directly ask us about. Because I think even today itself, when we're talking about American civilization and these foundational ideas, there are definitely things that your teachers won't directly point out, but we must continue to speculate and question all of these, the foundation of all of these systems.
Right, because oh no, I'm so sorry. Go ahead.
No, okay. I was just about to say keyword civilization, right? There was the idea that these countries, these European countries, are coming over to the Americas, right? And they're bringing civilization, right? Because the people there, they don't have a civilization.
Of course not.
No, they're not
no.
developed, right?
Right.
But really what they're bringing is much more, right? They're bringing disease, they're bringing oppression, they're bringing literal death, and their own modes of classifying people as like other people and different and lesser. So I think that like really ties into the dramatic effects that we see in like health for individuals, right? So like that's where these health disparities really come from.
A lot of them across the globe, like so much health disparity, health inequality is coming from structures that maybe were once set in place but were broken down by colonialism. And I mean, yeah, we're going to get into that. And we've kind of been hoping to focus our efforts more on that. I think Partners in Health is really hoping, and it's a part of the Paul Farmer Memorial Resolution, is focusing on the way systems of colonialism have made infrastructure even more difficult to set in place.
Exactly. And if you kind of read into that legislation, supporting ideas of reparation and funding for global health efforts is heavily emphasized, if not centrally, in the bill. One fun fact is even that Burundi, around the time of that colonialism period, it was called Rwanda, that broke up into Rwanda and Burundi. Burundi wants Germany and Belgium to pay $42.6 billion in reparations for colonial rule, which if you think about the magnitude of that amount of money, you think, oh my God, that's so much. But the fact that how far back Rwanda and Burundi have been set back by these colonial powers and the lasting impact of how that's allowed countries like Belgium and Germany to continue dominating in this world economic sphere without competitive powers that have been oppressed by them in the past is I mean, it quite levels.
Yeah.
And that's an economic analysis that you can definitely look up, and I believe it's very justified.
Right.
So why did we discuss this Rwanda genocide? Let's talk about that in the context of global health. We want to explain how this event would go on to drastically affect the ability of people to attain healthcare. One quote that Kadia Savchuk has is, "Many wrote the country off as a lost cause when it came to public health. A lost cause. Up to 1 million people had perished, and millions more were displaced. Hospitals and clinics lay in shambles. Most health workers had been killed or had fled. Widespread rape, disseminated HIV, and a massive cholera epidemic swept refugee camps. Fewer than 1 in 4 children were vaccinated against measles and polio. Rwanda was the poorest country in the world with the highest child mortality rate and the lowest life expectancy anywhere. And we're talking about 1994, the 90s, apparently when a lot of the trends that we see nowadays started not too long ago. 94 is only a couple of years before I was born and Raiye was born. That's
not that long ago at all.
Not that long ago. And we're talking about a country that was written off, was broken, didn't have any hope for their healthcare system, and was a international crisis. This is where the Rwandan people refused to give up on themselves. Refused to. The Rwandan people saw the gore of this event and saw the disaster that unfolded from these tensions, and realized that it was time to make a change for the better. I want to talk about quite a powerful individual who spearheaded one of these movements, the kind of right to health movement in Rwanda, is Dr. Benegwaho, who she has a speech on TED where she talks about this situation, and she talks about how going into this country, she went in from a European country, and her being Rwandan, she could easily just go back to her country or her foreign country, settle there and never worry about it. But she realized that she needed to take on kind of this hard movement. And yeah, honestly, I think that let's get into kind of some of the specifics of what the healthcare system, how it has developed and its general structure since then.
Okay, so yeah, I guess I can go into that. So the healthcare system in Rwanda had been adopted. Well, let me just start it by this. Like we said, Rwandan healthcare was non-existent, especially during the Rwandan genocide. But now it's one of the most sought after models. But yeah, so they follow a universal health insurance, which was adopted by the MOH, and it had become mandatory for all Rwandans, meaning that all Rwandans would be covered by the health insurance. And in 1985, before the genocide, Rwandan had adopted like a health strategy in order to uproot the colonial-based decentralized like management.
Yeah.
And they wanted to have a district level care to focus on the local healthcare needs. So the problem was that it didn't really pick up any pace. And then what happened was the 1994 genocide. So during this time, they had promised healthcare to all, and now no one could really receive that. So after this, nearly every one of Rwandan's 15,000 villages had elected community health workers.
Right.
And so after the increased presence of these community health workers, 80% of those who had required malaria treatment were now able to receive it, and they had vaccination rates that increased from under 30% in 1995. So this is a year after the genocide. Mm-hmm. And now we have 94% vaccination rates, and that was only 2015. So it's probably increased by now.
Right.
And so basically the way they worked is they used funding from the international community, and the healthcare infrastructure was able to grow. They were able to basically grow and provide not only just healthcare measures for individuals who had been hurt or injuries, they're able to provide primary prevention measures. So that includes vaccinations. So something that in America we have, right?
Yeah.
We have the ability to become vaccinated. Primary health care is not a problem. It's covered by all insurance, right? Mm-hmm. That's not something they had until they were able to have this structure.
And picking up on something Miriam said there, she said that Rwanda was able to use some of the funding that they were able to acquire from the international community. Looking at that statement, that shows how far a bill like the Paul Farmer Memorial Resolution can go.
Right.
If a country is able to be given allocation of resources that financially they're able to have a little bit of flexibility in terms of how they're able to develop their systems, the growth we've seen in Rwanda itself is tremendous. I mean, the most common illnesses in Rwanda are transmissible diseases. And this is a commonality in much of central to sub-Saharan Africa, is there are a lot of preventable diseases that can simply be improved by proper hygienic measures. Mm-hmm. A couple of these include things like malaria, HIV, tuberculosis, cholera, meningitis, and the pure numbers on how much these have improved simply by giving a little bit of funding to the healthcare sector has been incredible.
Mm-hmm. Yeah, so some of these healthcare indicators are basically for the quality of life. So if we're looking at something which is really important, like in America, we have maternal mortality that we really focus on here.
Yeah.
And here we have a lot of problems. But just in 2000, so this is 6 years after the genocide, they had a rate of around a maternal mortality rate, also known as an MMR, of around 1,600 per 100,000 live births. So after the implementation of this healthcare system in 2017, we now see a lower maternal mortality rate of 248 per 100,000 live births. And it's still a large number, but
it's improved.
The ability of these community healthcare workers, because that is their main form of healthcare, so that percentage decrease is so large. So back when we're looking in 1994 again, we had a life expectancy of around 28 years.
28 years.
How old are you guys?
Years, yeah.
How old are you guys?
I mean, I'm 20. That gives me 8 years left.
19.
I
got 9
years left. You have like less than 8 years left.
No, that's crazy.
No,
Yeah.
it's actually, it's horrible.
And the thing is it's, I mean, and I'm sure that number is brought down drastically by the infant mortality rate. I mean, it's children that aren't making it past the age of 3, 4, dying from cholera, tuberculosis, and
all these preventable diseases.
Mm-hmm.
And so now between 2018 and 2022, we have a life expectancy of like 69 years, which is, again, drastic. And so they're getting funding from an international community, right? But the people spearheading this is the country itself of Rwanda, right? So when we had this like colonial oppression, we saw none of that, right? We saw dramatic decrease in health for mothers, for infants, for overall life expectancy. And so we also have preventable infections, right? So things that we have everywhere.
And so even with preventable infectious disease, Miriam kind of covered that earlier a little bit. She kind of had introduced this statistic of 80% of those requiring malaria treatment are now able to receive it. And vaccinations rates having gone up over 60%. The fact that 20, 30 years ago, Rwanda had a rate of vaccinations that low they're still suffering from the effects of that today.
And that's because, these colonizing countries, they don't care. They don't care about the health systems in the countries that they're taking over. They don't care about setting in place infrastructure that's going to vaccinate the populations. Like, they're not there for that. They're there to extract resources and go. So, it's kind of expected. As grim as it is.
Just like you said, they don't care, right?
Yeah.
So when we're looking at World Bank, they also have like requirements. So they won't put certain statistics if your country is not capable of providing reliable statistics, or any statistics for that matter. It's not there. In World Bank, you can pass through every single year of like the United States. Every statistic is there.
Right.
If you're looking at Rwanda during the genocide and during colonial oppression, there are no statistics.
Nothing. Yeah.
So we have no idea what the tuberculosis incidence was. We don't know what the prevalence was at all.
Yeah.
But by the time they had their own, they were able to successfully have surveillance for their communities. And surveillance is basically looking at the rates of infection, the rates of prevalence of a certain disease in your community. And so they got it down to 58 per 100,000 people, which is incredibly low for developing countries, especially in Africa.
Right.
And so if we're talking about the model as to how Rwanda got into this level of impact on their healthcare system, we must look at the partnership and accompaniment, this core PIH concept that we continue to talk about. In this specific Butero District Hospital, a lot of these models that don't include this idea of partnership are quite akin to colonial oppression, if you think about it. An organization that thinks they know what they're doing goes into a country with their own interests in mind and has no clue what these people in these communities face on a day-to-day basis, try to push out this set of principles and set of ideas to improve healthcare outcomes, and it completely just is nowhere near as effective as if these countries are able to be partnered with. And that's exactly why Partners in Health partnered with the Rwandan MOH in order to kind of address the problems by giving support rather than giving command. And so the Butero District Hospital has a lot of specific goals in mind to account for transmissible diseases, including cross-ventilation systems, spatial triage systems, and finally, with the expansion that is currently occurring to the Butero District, it will bring this hospital bed ratio to 1 bed per 1,500 people in comparison to this statistic that we had talked about earlier at the beginning of our segment, 340,000 people.
Wow.
Still nowhere near our Austin bed ratio of about 350, but it's a lot of progress that has been made in which the Rwandan Health Ministry has been able to connect with a international agency in order to partner and be provided resources and to keep themselves open to financially be able to have flexibility with this system.
Yeah, and we said this is Partners in Health's main fundraising focus for this campaign year. And so all that information is kind of giving background as to why it's so important to Partners in Health, as to why it was important to Paul Farmer. It's why we've expended so many resources. So to quote the late Dr. Paul Farmer himself, equity is the only acceptable goal. And I mean, like, that has rung true for so long. And when we talk about working in solidarity with these communities, we have got to work alongside them, bring them up to where everyone else is, as opposed to trying to allocate resources to everyone, which is kind of what equality means. We want to focus on the ones that need it the most. And right now, Butero District, Rwanda in particular, that's what it's looking like.
And we're really excited to be able to continue discussing different case studies in different countries. We'll get even deeper into some of these stories of what's going on, not only in the past 30 years, but right now. And that will get really interesting, and that's for a future segment. But
yeah,
hope to see you soon.
Thank y'all for listening, and we'll be back.